Provisional Health Advisor, Coast Province for Danida, and some of us have joined International Open University. Dr. Dabar Abdi is the Chairman Board of Trustees, International Open University IOU. I can spend the whole day talking about this giant. He doesn't look like a giant, he's small like me, but we welcome you, Dr. Dabar. We are all pleasure to have you here. Thank you.
How long is each person? How long? Each speaker has got how many minutes? السلام عليكم ورحمة الله وبركاته. إن الحمد لله نحمده ونستعينه ونستغفره وأشهد أن لا إله إلا الله وحده لا شريك له وأشهد أن محمدًا عبده ورسوله. We thank Allah subhanahu wa ta'ala for bringing us back together, having a wonderful lunch after had wonderful sessions in the morning, and we should count this ni'mah because right now the Gaza people are having rains of bullets on their heads, but alhamdulillah we are sitting in this comfortable situation. We thank Allah subhanahu wa ta'ala. I've been given to moderate this session with a very group of eminent scholars, and inshallah we'll give each of them 15 minutes. And our first speaker is Dr. Ajang Ajua, Ngenja Ajua, consultant gastroenterologist, Aga Khan University, Nairobi. Is he here? Dr. Ajua, are you here? Oh, karibu, karibu, karibu. We'll start with him, and we have others as you can see the program. Dr. will give you 15 minutes, and the questions and answers will come later on as a joint group. Shukran.
All right, thank you. Good afternoon, everybody. And thank you very much, the organizers, for inviting us over for this wonderful conference. My name is Dr. Ajua, has spoken. And thank you very much to the moderator for the introduction. Initially in the program, when I noticed on the soft copy, I don't know if it was printed in the same manner, they picked out just the other part of my work at GastroHub, which is my unit. And they failed to include Aga Khan there. I think somebody was trying to lead to my downfall, but I worship a living God. So I work for Aga Khan University Hospital part-time, and I also work for GastroHub Clinic. So today we're going to go through H. pylori therapy. What are the modern concepts of H. pylori therapy? There's a lot of changes that have occurred over the last couple of years, which I think are important for people to keep being updated about. There's a lot of issues regarding testing and treating. It's becoming sort of a pandemic. It has taken over from typhoid, and the other guy was brucella. Now everybody is just running H. pylori tests on any walking object, including animals, I suspect. So I'll take you to two cases quickly. So a 40-year-old male presented with colicky abdominal pains for 5 days, associated with bloating, diarrhea, and vomiting. Both were not bloody in nature. Also reported some malaise and fevers. Seen at a nearby chemist, and stool and blood tests were done. Stool for H. pylori, antigen was negative, blood antibody was positive. He was then given an H. pylori kit, joy to the world as usual, and he was given amoxicillin, clarithrol, and omeprazole. He reported that the symptoms worsened a few days later, and he came in for consultation. General exam was pretty much normal. There was mild tenderness generalized in the abdomen. So what we did was just stop the kit, basically. Did a stool microscopy test. We got some pus cells, and his stool antigen test for salmonella. Salmonella antigen test was positive. So we just admitted him and put him on ceftriaxone therapy, and he did well and left for home. So I took off the second case because of time. The second case was almost similar. However, this patient was treated 4 consecutive times for H. pylori therapy. And after we saw him, did further investigations, including a CT scan and an endoscopy, we ended up finding that he had a pancreatic tumor. So the above scenarios are very common. We see this all the time. Abdominal complaints are among the commonest causes of visits to all our medical institutions. H. pylori testing is among the most common ordered tests in our OPDs at the moment in Kenya. And fortunately or unfortunately, the chemist is a very, very key cog in the over-the-counter management of our patients with abdominal complaints. Majority of our patients probably in Kenya walk into the nearest chemist as they go about their daily business. So what are the principles and practice of H. pylori diagnosis and management? Patient selection is extremely important, as I mentioned. Not all abdominal pain, as you've seen from the single case we presented and the other one which I have spoken about, are H. pylori related. Choice of the test is also important. And very, very critically, if you do go ahead and test a patient for H. pylori, it's very important that you try to succeed at the first attempt. There's a whole lot of work going on antimicrobial stewardship, and really this has a very, very key role. Try to succeed at the first attempt. How do you do that? You have to know your local resistance patterns and the history of the patient's recent antibiotic use. So, the who. Who do we test for H. pylori? Very important. This is the list of people you should test for H. pylori and nobody else. A patient who comes in with dyspeptic symptoms, a patient who comes in with GERD symptoms, which form part of dyspepsia to some extent. Universal screening in Kenya, not really something we are talking about nowadays, because the truth is the incidence of H. pylori-associated gastritis, gastric carcinoma in Kenya and in Africa in general is very, very, very low. Slightly different in the East and the West. There they have every reason to test almost anybody they want for H. pylori. We really don't. So basically, let me take you through a small recap on what dyspepsia is. So dyspepsia is described as a recurrent or persistent episodic abdominal pains or discomfort, or any other symptoms which are referable to the upper alimentary tract. This excludes jaundice. If you have any of those above symptoms and you have jaundice, it's not very, very much, it doesn't fall into dyspepsia per se. You might have both dyspepsia, but definitely you also have a liver issue. What are the symptoms? Abdominal pain and discomfort, heartburn or other manifestations of GERD, anorexia, nausea and vomiting, flatus, flatulence, or air eradication, which is your belching, burping, etc. So, what this is trying to tell you is that we need to, as I mentioned, we need to stop threatening people with H. pylori testing, kindly. I'm sure you all know Liam Neeson. So, the what? How do we test, and what are the tests which are appropriate and available? We have non-invasive methods, which is the urea breath test, for instance. The stool antigen test is the other one. Serology, which we do now from in blood, etc., for H. pylori. So those are the three non-invasive methods which we have. Urea breath test, unfortunately, we do not have it available in Kenya locally yet. The stool antigen test is a very, very good test. It has a very good specificity and sensitivity. That's probably the most key test which, if you do want to run, that's probably the main one to use. Serology, I would probably put an X on that and tell us, please avoid using blood for testing for H. pylori. The reason is, as we all know from our basic immunology, your antibodies can remain positive for ages and ages, despite you not being positive for the active organism. Invasive methods, those are mostly what we get through endoscopy. We take the samples and we run stains on them, etc., etc. So please don't do that. So, the how. How do we manage patients for H. pylori? So, choice of first-line therapy will depend on a number of things. The local resistance rates to the flagship antibiotics. Flagship antibiotics here are basically your clarithromycin, your flagyl. Now, this is slightly now in the past, as you will see as we're going forward. These have been the flagship antibiotics for decades and decades in the past. Resistance rates above 15% to either of those molecules render the molecules less effective in the therapy of H. pylori. And ideally, according to the American guidelines, European guidelines, etc., once you get to 15% resistance rates in your local environment, ideally you should do away with those antibiotics for H. pylori therapy. The other thing you need to consider is the patient treatment naive? Is it the first time the patient has been treated? Is it a retreatment? That will guide your first-line therapy. The other thing is recent antibiotic use is very, very key. COVID has thrown us into a bit of a tailspin because we were all popping microlides like peppermints, azithromycin, and the rest were all on board. Since nobody knew what to do with COVID, we were all shaking, and so everything was used, and especially microlides. So that might pose a problem in the future. And then the last thing, the adverse drug reactions, of course, to the various antibiotics. You have to be aware of that in your patients. So there are various treatment guidelines around the world. Maastricht is probably the most famous of them all, where they talked about 2 or 3 things in terms of first-line regimens. So in areas where you have less than 15% resistance to clarithromycin, the advice was for standard therapy using clarithromycin. So this is what we are doing at the moment, almost across the board, which will change. So first line in Kenya generally currently is amoxicillin clarithromycin and a PPI, or flagyl clarithromycin and the PPI. The second line for the longest time has been the levofloxacin-based regimes, or your quadruple therapy. Salvage therapy remains your rifabutin. So standard therapy essentially seems to be slowly on its way out, and you'll see why and how. As I mentioned, we need to try and hit it quick and fast early enough. And to do that, we need to have the appropriate weapons to achieve eradication of H. pylori in the patients who you decide to treat. So avoid bringing a knife to a gunfight. You may be wondering how we got here and things like that, and why are we changing? Why do we need to change the regimes which we have been using, which have been working from the past? And this thing really made me think about that a lot, because it makes you wonder, how did we get to where we got there? I always wonder how Trump got to the White House, and also how Arsenal got to the top of the table, but that's a story for another time. So how did we get to where we've gotten, where we might have to start changing our regimes? This was a study by Moisi et al. In 2018, published in the Journal of Research in Farm Practice. And it was done in 3 pharmacy sites in different socioeconomic zones. And they were trying to evaluate the extent of self-medication of antibiotics and dispensing practices in Kenya. It was done over a 3-month period. And what they found was pretty interesting. Prescriptions were checked for the validity in 96.9%. Dispensing was undertaken with a valid prescription only at 94.1% of the time. Dispensing antibiotics, no prescription by pharmacy staff, 4.1%. Really amazing, really amazing things. This was basically a table of the types of antibiotics that were prescribed the most. Penicillins, as usual, were the majority, amoxicillins and the rest, which was expected. So that's all very well and good when you look at it. It seems like people were not dispensing antibiotics without a prior prescription. But truth is, on the ground, things are usually different. So a Synovate poll in 2011, they looked at 70% of 203 pharmacies which were sampled in the 8 provinces. Back then, there were still provinces. Actually did not require you to have a prescription before they dispense a prescription-only drug. And as much as I used to find Synovate, they have changed now to another company. I can't remember what they're called now. As much as I find them to be a little bit funny with when they're doing the political sampling and all those things, I actually do believe in this one more than the other study by Dr. Moisi et al. Because this one usually I think is more of the truth, and we all know that when we go into chemist, you can buy pretty much anything in Africa without a prescription. So where are we now in terms of a timeline of resistance? How have we gotten to where we've gotten? This is the drug susceptibility patterns of H. pylori patients with dyspepsia. That is not possible. Yeah, it's absolutely not possible. I started at 5 minutes to 3. I've done 7 minutes actually. Yeah, so I actually have 8 more minutes to it, to be honest. I actually do keep time quite well. I try to. So I'll just take you through this. So basically this looks at the resistance over time. Metronidazole, we're looking at resistance rates of the high 90%. I'll take you to the most recent study, 2020. This is one of the best studies so far, looking at susceptibility profile to H. pylori isolates from patients with dyspepsia in KNH and RB Hospital. And what did they find? Now this is very interesting. Clarithromycin, look at the resistance rates. Overall, at the last column, we're now at 13.2% overall resistance rates of H. pylori to clarithromycin. Amoxicillin, the next step, resistance rate of 0. Still remains a very, very excellent drug in our fight against H. pylori. Metronidazole, as we can see, almost a worthless drug at the moment, 80.9% resistance rate. Levo 2.9, Cipro 2.9, and with that in mind, chances are metronidazole for sure, just flush it down the toilet for now when you're coming to H. pylori therapy. Do not use it at all. It's going to be probably worthless. Clarithromycin, we still have a bit of leeway, but my advice would probably be we should try put it back on the back burner a little bit. As we all know, what happens is when you stop an antibiotic in an area for a couple of years, slowly the microbes lose the resistance to the antibiotic and you can reintroduce it again later. So this is where we should be at the moment. First line in Kenya should be amoxicillin, clarithromycin, and a PCAB or a PPI plus a probiotic. This should be used in patients who are treatment naive and who have a very low antibiotic history use. The other way you can do it is using amoxicillin, levo, and a PCAB. I will tell you what PCABs are soon, or a PPI and a probiotic. Or the other option you have in first-line therapy is what they call dual therapy. This is a pretty newish concept, which I use a lot nowadays, and it works quite well. It's a high dose of amoxicillin of 1 gram 3 times a day or even 4 times in a day, plus a PCAB or a PPI. The PCAB here we're talking about is the flagship PCAB here is what they call vonoprazan. Second line in Kenya should be bismuth quadruple therapy, consisting of bismuth plus a PCAB, plus a PPI, plus 2 antibiotics, your amoxicillin, levo, or tetra. This line can be used as first line if you're not sure of the past antibiotic profile use of the patient. And third line remains salvage therapy with rifabutin. Note that all treatments require 14 days. Post-treatment testing of your H. pylori to confirm eradication is very, very key. We tend to forget that a lot. And remember that all the above therapies require a very high dose of your acid-suppressing medication. That is very, very, very key. And the evidence for the issue of high PPI dosage is very, very clear. Eradication rates are clearly better the higher the PPI dose. Basically meaning the lower the higher the pH of the environment. So I'll take you through briefly the dual therapy concept. It's driven by 5 tenets. 1, the need to reduce antimicrobial resistance. The need to maintain gut microbiota richness. Need to reduce adverse drug reaction profiles, cost effectiveness, and above all, maintaining a high level of eradication nonetheless. So this is just studies which basically are comparing dual therapy versus your standard therapy. And long story short, dual therapy is equal to or even better in some cases than your standard triple therapy regimens. So I'll take you through the PCAB. So PCABs are basically what we call potassium competitive acid blockers. They're slightly different from your regular PPIs. They're not as new as people think because they just came out in the market recently. They've been there since 2015 in Japan. So they're extremely potent drugs, 30 times more than PPIs, faster acting and longer lasting acid suppression. And studies have shown that they also have a better eradication rate in H. pylori when you use them. How they work is a little bit complicated, but briefly what I will explain it to you is, 1, it's not a prodrug unlike your PPI. It's an active substance already. Once you take it in, it starts acting there and then within your stomach. That's number 1. Number 2, the fact that it is not a prodrug also makes it more resistant to the acid environment in your stomach. It gives it a longer lasting action. And the more longer it lasts in the stomach lining, the better it works in the parietal cells, the better it works on your pH, etc., etc. Those are all studies taking you through the use of vonoprazan in dual therapy. And basically, long story short, once more, they're very, very clear in terms of the efficacy of your vonoprazan together with amoxicillin as eradication therapy for H. pylori. You must have seen in my list of medications, probiotics were mentioned in every single one of the groups. Why do you use probiotics? They're very, very important adjuncts to your eradication of H. pylori. They do that by various methods. 1, they safeguard your gut, your microbiome diversity. And number 2, they act in a synergistic way together with your PPI therapy and your antibiotics to help you eradicate your H. pylori. These are all studies which basically prove that. And finally, a very interesting novel thing which we might be moving to in the next 10, 20, 30 years. So GI map is a very interesting thing. It's a DNA-based PCR stool test. So what basically it does is it's able to map and quantitatively assess your general microbiome. And in particular, if you want to do H. pylori, there's a particular kit for that. So you can pick up H. pylori and give you the genetic line of the H. pylori which you're dealing with in your individual patient. And what that does is you're able to then target the patients who are at higher risk for potentially developing cancer of the stomach in the future, should you not eradicate the H. pylori in them. The two main genes are VAC-A and CAG-A, which are the most important genes in your H. pylori. CAG-A is the one which has been noted to be the main driver of carcinoma of the stomach. So if you do a GI map test on your patient's stool, and the H. pylori they have does not have the CAG-A gene, you're pretty much free not to even bother treating the patient, especially in the case of our area whereby people are testing patients for H. pylori when they do not actually need to test them. Then you can just let the H. pylori be, actually. Good. So finally, let's all try and kick in the same direction. Let's all try kick in the same direction. Let's do the right things for our patients. H. pylori is not a death sentence. It's not a very, very high risk in our environment. Test and treat, but test only those who really do need to be tested, which are your patients with dyspepsia, GERD, etc., etc. Thank you very much.
Thank you very much, Dr. That was really great. We'll give you more time, maybe during the question time. Okay, our second presenter is Dr. Mohammed Rashid. Karibu. Dr. Mohammed Rashid is an orthopedic surgeon, specialized in spine surgery. He's undergraduate and postgraduate. We are both at the University of Nairobi. Subspecialist in surgery at Macquarie University in Sydney, country station at Coast General. And his main area of interest is cervical spine. Karibu. Many of us have got those problems, by the way.
Okay, assalamu alaikum. Okay, today I'll just make a brief presentation on cervical spondylotic myelopathy. Why I chose this topic is because it's quite common, and most referrals come fairly late when it's stage 4 or 5 disease, when really, even if you operate, the improvement is not as good as when it's early. So cervical spondylotic myelopathy is the most common cause of spinal cord compression. It's basically a disease of the elderly. It mainly occurs in people in their 60s, and men are more affected than females. It's a degenerative condition whereby you have various forms of degeneration occurring in the cervical spine, which compress the spinal cord with resultant deterioration of neural function. So most patients will present with some form of paresthesia or subtle loss of function. For example, their handwriting changes, they have difficulty in buttoning shirts, they have difficulty in walking from the bed to the toilet when it's dark. Neck pain is a really rare symptom that most patients don't present with. Some will come with weakness. Again, weakness is usually a late symptom. Incontinence of urine and stool is also a very late symptom. By the time it occurs, usually even to reverse it is difficult. So the diagnosis relies heavily on physical examination. When you physically examine this patient, again, some will have weakness, but again, this is difficult to quantify in early disease. But there are pathognomonic signs for the myelopathy. One of the most common is a Hoffman sign, which that's the Hoffman sign. If you flicker the finger, all the fingers flex. It's one of the signs of upper motor neuron lesion. There's also the inverted radial reflex. If you tap along the brachia radialis, all the fingers flex. These are pathognomonic, basically, of having myelopathy. Clonus, again. I mean, it's self-descriptive. There, you can have a Babinski sign. So The presence of these signs actually almost certainly tells you that the patient is myelopathic. The next thing, you'll want to investigate the patients. Again, you can begin with simple x-rays. I mainly use x-rays to check for alignment, and this helps me make a surgical decision. I do not use them basically to make any diagnosis. The gold standard to make this diagnosis is actually an MRI, which will show cord signal changes and various factors that compress the spinal cord, which can include disc osteophyte complexes or hypertrophy of the ligament, especially the flavum. Sometimes you can also have spondylolisthesis, which is basically instability of the spine that causes the spine to move and compress the spinal cord. I find nerve conduction studies having little value. So this is an MRI of one of our patients. Actually, this patient is young. He was only 33 years. It shows that there are disc herniations at, it doesn't point, but there are disc herniation at C3, C4, and C4, C5. They've been there for years. They're compressing his spinal cord so much, and he basically came completely myelopathic, maximum grade of neuric grade 5. Those are the actual scans. So you can see the spinal cord is being really compressed by the disc herniation in this case. I basically do CT scans. Next. I basically do CT scans to check if the compression coming from the disc osteophyte complexes is ossified or not. As you can see here, the pointer is not working. You can see some of the compressive elements are ossified. In these cases, if you go through the front of the spine to try to decompress, you'll most definitely paralyze the patient. So the CT scan is not used for any other function other than to check if there's ossification so that it can help guide what surgery you're going to do. Are you going to go through the front or go through the back? So there are various classification systems for this myelopathy. By far the most common is the neuric grading system. So it grades it according to the functional ability. So you have grade 0 to grade 5. Grade 0 basically is a patient who is at risk, just has root signs, but when you do an MRI, the spinal cord signal is normal. Grade 1 is there's signs of spinal cord involvement. For example, patient has a positive Hoffman's, but is walking normally, has no functional limitation. Grade 2, there is a difficulty in walking, but the patient is still employable. And grade 3, patient is no longer employable. Grade 4 can only ambulate with assistance, and grade 5 is wheelchair bound, basically, or bedridden. Most of our patients actually come in grade 5. So you should always remember differentials. We've had several cases with patients with multiple sclerosis, actually, and it's been referred as a myelopathic patient. So if things don't make sense, you better get a neurologist to see the patient so that he can rule out these differentials. So basically, for me, myelopathy is either you treat or observe. There is no middle ground. So either you're deciding you are treating surgically or you're just observing the patient. And when do you decide to treat surgically? Most importantly, if there is impaired function, that is, patient is neuric grade 2 and above, the patient can no longer function, is not employable, then it's better you intervene. If the patient is progressive in terms of neurological deterioration, you better intervene. If on the MRI that there is a space available for the cord is less than 4 millimeters, also you intervene. For this disease, the most important prognostic factor is actually the stage of disease. You cannot bring a patient to stage 5 who's on a wheelchair back to stage 1 or 2. So it emphasizes the importance of intervening early. You have to refer the patients when they're still in stage 0, 1, or 2, because if they come at stage 4, 5, you can improve them, but it makes the improvement little and makes the surgery more dangerous because there's very little space to work on. So what are the operative options? Basically, for 1 or 2 level disease, you go through the front, so you do anterior decompression and fusion. If there's retrovertebral disease, which is basically not only the disc compressing the cord, but there's also bony elements behind the vertebra, body compressing the bone, you need to remove the vertebral body. So that's called corpectomy. This only for 1 or 2 levels. If there are 3 or more levels, you better go through the back, so long as there is no kyphosis. If there is kyphosis in the neck, going through the back will actually harm the patient. So in the back, you can either do laminoplasty, which means you're just opening up space by releasing part of the lamina, or you can remove the whole lamina, so it's called laminectomy, and fuse with screws. So we have a few local cases which will demonstrate what we've just described. So cervical spondylotic myelopathy is the 3rd most common condition we operate at Coast General, behind TB, spine, and trauma, of course. So over the past 1 year, we operated about 24 cases. You can see the second line, all the patients who came were either new grade 4 or 5. There was no single patient who came at grade 0, 1, or 2, or 3 even. So most of them, they'll come on wheelchairs, or they'll come on ambulatory walkers on full support. This makes the surgery more difficult. It also makes it less beneficial to the patient. However, despite this, we've had neurological improvement in 23 out of 24 cases. Only 1 patient had neurological decline. Surprisingly, ours, they were either improving or not improving. There was no middle ground. And the one for the neurological decline had white coat syndrome, which basically, if the patient is very tight, the cord is being compressed chronically for long, it's been cut off blood supply, you suddenly increase the blood supply to it by decompressing it. The oxygen radicals, which cause more damage. We tried to reoperate the patient by decompressing more after developing white coat syndrome, but unfortunately did not improve. The challenges we have, of course, the most important challenge is late referral. If there is a lot of stenosis, the surgery becomes very dangerous. I keep on repeating that because the instrument we use to decompress the spinal cord is called a Kerrison Rongoa. We introduce it in between the disc space. Now, if they come when the space available is less than 4 millimeters, and Rongoa itself is 2 millimeters, every time you introduce it to decompress, you risk paralyzing the patient. I typically don't use neuromonitoring for cervical myelopathy. It's not a standard of care, but it's good to have. So this is just one of the cases we did recently. You can see there's a disc herniation there at C6, C7. The cord is being compressed, both from the front by a disc osteophyte complex and from the back due to hypertrophy of the ligamentum flavum. So for this case, it's a single level disease. We just went through the front by performing an ACDF at C6, C7. So this was the case, the MRI images we had presented earlier. This is a young man, 33 years, who had been myelopathic for over 2 years. So we did 2-level ACDF. ACDF is the most common operation done for these cases. So again, this is another case we did at Coast General. The middle picture just shows lateral mass screws. The center is the spinal cord that's now been decompressed. So for such a case where there are osteophytes that are ossified, on the CT image, if you go through the front in this patient, the patient will definitely be paralyzed. So this is another case. Again, you can see that there are a lot of cord signal changes in the compression, both from the front and the back of the spine. We did 2-stage surgery in this patient. The first stage, we went through the front, removed the disc osteophyte complexes compressing the spinal cord, and then took the patient back to the ward. We did an MRI. We're not happy with the degree of decompression, so we went through the back. Now, the surgery for cervical myelopathy is extremely sensitive in that if you do an incomplete decompression, it's worse than not decompressing the patient at all. Because what happens is any surgery will create cord edema. When the cord swells and you haven't released all the space, the patient actually worsens post-op. This patient did not worsen. We were just not happy with the post-op MRI. It's good to do post-op MRIs for all patients you operate with to check the adequacy of decompression. So we went through the back and also decompressed the same patient from the back. Again, for myelopathy, if you don't, there's a thin line between success and failure. If you don't reach the line, you will not succeed. If you overcross the line, there'll also be problems. So if you don't decompress adequately, the patient will not improve. But if you over-decompress, you'll chew out so much bone that the patient will have instability. So it's a delicate balance. You just remove what is enough, and that's it. So the take-home message after all this is that cervical spondylotic myelopathy is the most common cause of spinal cord compression. The disease often progresses. We know that. If no intervention done, it will progress. It is important to refer these patients early, because the likelihood of surgery improving the patient is less when the patient is an advanced neuric stage. And surgery is the only treatment modality that offers a predictable good outcome. Thank you.
Thank you very much. Thank you very much. That was really great. And now we have our last presenter, Dr. Mwakio. Dr. Mwakio is a consultant dermatologist, skin specialist based at Massaburi County Referral Hospital. He has recently enrolled in fellowship in aesthetic medicine, where he has interest. Dr. Mwakio, karibu tafadhali. Thank you.
Thank you so much, Dr. Malin, for that kind introduction. Thank you so much, Kammp and L'Oreal, for inviting me for this talk. It's my first time being here, so I hope you learn a thing or two. So what I'll talk about today is just is acne, a common skin condition. So I'll just go through clinical presentation and management of it. So I think we can start.
It was there just after Mohamed Rashid's presentation.
It's there. There is the first slide, but then it's empty. Let's just use his. He has the.
So basically today I'll be talking about acne, a common skin condition. So I'll just go through the clinical presentation and management of acne. So what exactly is acne, which I'm sure you all know? So it's a common disorder of the pilosebaceous unit. So this unit consists of the hair follicles, sebaceous glands, and erector pili muscle. So this pilosebaceous unit is found everywhere in the body except the palms and the sole, and common in adolescents, and less common in the adults. So basically this is what we'll be talking about, the pilosebaceous unit. This is how it looks like. You can see the hair follicles in the skin, sebaceous glands, and the sebum that is produced by the sebaceous glands. So you might be wondering, why should we worry about acne? So for the majority of the patients, they'll not have really a big issue. It's a limited cause, it will clear. But unfortunately for some of these patients will have long life complications, scar formation, disfigurement, and pain. Apart from just acne being condition of the skin, it has also a psychological impairment. Unfortunately, some of these patients will lose confidence, and unfortunately some of them will fall into depression. Apart from acne also being a condition of the skin, it has been compared to patients suffering other chronic diseases like asthma, eczema, and diabetes. So it's beyond the skin. So reason why we need to treat. Epidemiology, so mostly, as I talked about earlier, mostly in the adolescent and young children, this is about 85%. We have a small variant where we have the neonatal acne, and some of these patients have a positive family history of of acne. Yeah, so pathophysiology, so as I said, typically it begins at puberty and the disorder of the pilosebaceous unit. So majority of the cases where you'll get acne mainly will be the face, chest, back, and rarely do you get acne below your waistline. Most of these patients generally have an oily skin due to the sebum production. So certain factors have been identified that contribute to formation of acne. So what you have, the follicular epidermal hyperproliferation that leads to blockage of the follicular opening. Another issue is also increase in sebum production, which is under the influence of androgen hormones and bacteria, which has been renamed, it's known Cutibacterium acne. This generates inflammation in the acne skin lesions. So generally, we just have the abnormal keratinization, desquamation, and leading to the blockage of the pilosebaceous duct and the bacteria that proliferates due to the excess sebum and breakdown of fatty acids. We also have a role of pro-inflammatory mediators that activated and lead to result in inflammatory acne. So in the study that you have seen, most of patients, adolescents, male patients have a higher rate of acne as compared to female patients, but mostly this is in adolescents. But in adulthood, more female patients have acne as compared to male patients. Other studies have shown there's a variant called nodulocystic acne, which I'll show in the subsequent slides. So this is a severe variant of acne. It's more common in white patients than black patients. So how would we treat, how would we classify acne? So treatment of acne mainly will be based on the classification. So there is no clear-cut classification, but commonly what is used is the appearance of the lesion. So mostly we'll have the mild, moderate, and severe. So reason why do we need to classify acne? Different treatment will depend on the severity of acne. So in mild acne, what mostly you'll get, which I'll show in the following slides, you'll get the comedones. So this commonly what you'll get, whiteheads and blackheads, that is commonly present. So basically the difference is that the open comedones are those that are exposed to the external environment, leading to oxidation. That's the appearance of the blackheads. So other than that, we have the mild acne, moderate and severe. So moderate will just have addition, papules and pustules, and severe acne is when you have now the nodules, you have all these, probably all these complications, scarring, abscess, formation, and things like that. So this is just a photo just showing how the pilosebaceous unit looks. How A shows the normal hair follicle, the open comedone, which the color has changed, which will get the blackheads, closed comedone, whiteheads, papules, and pustules. So in an acne patient, you can get all these skin lesions in one patient, or one or two may be present. So as I talked about earlier, primarily acne can affect the face, trunk, and all these other areas, but most commonly the face. Chest, back also are areas that acne can affect. Other changes you might get is post-inflammatory changes. This occurs due to sort of complications of acne. You'll get post-inflammatory hyperpigmentation, which with time will resolve or may need treatment. One thing I'd like to talk about is scarring. So you might be wondering, why do we need to treat acne? So due to the risk of scarring. So the more severe the acne is, the higher risk of scarring might occur. So what can you get? For example, in severe acne, you can get the scarring, you can get hypertrophic scars and keloids and things like that. So I hope you can You can see in the photo the white heads. I hope you can be able to appreciate there's some white papules there. So that is what we call the closed comedones, commonly referred as whiteheads. From the next slide, this is what you can get in some patients, open comedones, so commonly also referred as blackheads. I hope you can be able to note the opening with the hyperpigmented papules. In some patients, you might get papules that may be seen in acne. Most commonly, as you can see, all the papules are in the same size. There's a variant of acne called steroid-induced acne, so you'll get monomorphic lesions. This can be also due to drug-induced, especially in patients you're treating for other conditions. For example, steroids, they might get something called steroid-induced acne. Mostly the lesions will be monomorphic, meaning all the lesions will be in one size. Apart from the comedones that I talked about, other skin lesions that you may get are pustules, which also are common in acne. So as you can see the appearance, probably this needs to be treated. From this picture, maybe you might have seen a case or two like this. So these are severe variant of acne. I hope you can appreciate the presence of the nodules, abscess formation, and things like that. So these are more severe variant of acne, so treatment must be initiated. So such patients are quite at high risk of developing hypertrophic scars, keloids, and things like that. So treatment is warranted. So at times the acne papules can be quite inflamed and itchy. So you might notice some of these patients might start picking on them, later leading to post-inflammatory hyperpigmentation or maybe possibly secondary infection. So basically just another photo showing severe form of acne. So this is called a nodulocystic type of acne. So it's a severe form of acne. In the picture, you just see what complications you can get. You can see atrophic scarring, hypertrophic, can get keloids, pieto. Commonly, in patients with untreated acne, some of these features you may not. So if you see such complications, unfortunately, it's patients who have stayed long without treatment and need to be treated. Some of these, I'd say, complications can be treated, but can be a challenge a bit. So probably best start early treatment to avoid such complications. So what are some of the risk factors probably that might not really cause acne, but exacerbate acne? We can have friction or manipulation. So at times aggressive scrubbing or things like that may cause your acne to flare. Occlusive products, for example, oils, olive oil or certain oils may lead to blockage of a pores actually inducing acne. Other close-fitting clothes may include the pilosebaceous duct. As you can remember, during the period of COVID, we all were wearing masks. We had something called maskne, which was mask-induced acne. So this was quite common during the COVID period. Some medications also have been noted to cause acne. Of note, especially steroids, as I talked about earlier, steroid-induced acne. So once the medication is stopped, the acne will resolve. A common question that we get, what is the connection between acne, diet, and things like that? So this is a bit controversial, though currently there are no specific studies heavily supporting this. But most patients, of course, they believe that food, certain foods, chocolate, sweets, eggs, milk, increase or worsen their acne. But there is currently no concrete studies to support this. The only thing I'd advise my patients, just if you suspect maybe something is triggering your flare, probably you just reduce the quantity of the foods you're eating. Other thing that has been noted is stress. So this is a study was done in students in the UK who were sitting for the exam. These are patients who had acne. During the period of the exams, the acne had flared. So stress also could be a contributing factor. But I'm sure we can't live without stress. So complications of acne, some of them I've already talked about them. So what you can get is a post-inflammatory hyperpigmentation, which is quite common you might see in patients. I also talked about scarring. This is what you might get in some patients. So these are patients who have had chronic acne, probably not been treated or came late for treatment. So some of these complications may occur. So after treating acne, you need to now plan management for, for treating the acne scars. Yeah, I'm almost done. Yeah. So I'll just go through quickly. So basically these patients who had chronic acne, so these are before and after. So some treatments might be used. I'll quickly go through them. So this is how, if you can appreciate how it might look after treatment. So with acne scarring, the treatment will improve the scarring, but in some patients, do not completely remove the scarring, but at least it will improve the appearance. So before and after, unfortunately, some patients might need more than one session of treatment. Yeah, I talked about hypertrophic scars. So for this, they may need some intralesional injections, glucocorticosteroids, but you have to be keen to note that you have to use a lower dose. So you have to know there's a risk of atrophy and also hypopigmentation. So be keen in noting that if you're to inject intralesional steroids, you need to use quite a low dose. So I'll just go through, I think my time, yeah, I think I have a few more minutes. So treatment, just basic, the thing is, when you're using, for example, cleansers, I know it may sound obvious, but some of the treatment, some of the products that you use to treat acne actually contain salicylic acid, benzyl peroxide, and things like that. So when you're getting soaps, don't get soaps or products with high concentration of these substance. Reason being, you might not be able to actually tolerate the medicine, because some of the medication, some benzyl peroxide may cause some irritation. And if you get some of these products, just gently scrub and don't be very aggressive in that. Other than that, you need to use rather products that, what we call them, that are non-comedogenic. So these are sunscreens that specifically designed for acne skin, and oil-free moisturizers for acne-prone skin that has an increased sebum production. So treatment, we'll go through, so I'll just talk about the topical treatment, systemic treatment. So treatment varies in terms of severity. So for mild acne, what you can use topical treatment will work quite well. So what is available in a local market is the topical retinoids, topical clindamycin, and benzyl peroxide. Azelaic acid and dapsone are not so common in our Kenyan market. So these can be used. For acne treatment, we recommend dual therapy to avoid resistance, bacterial resistance. So topical retinoids are excellent for acne treatment, has anti-inflammatory action, improves follicular desquamation, and also reduces hyperpigmentation. Of note is that you need to be patient when treating patients with acne. You might not be able to see changes at least for the first 4 to 6 weeks, so you need to not rather advise the patient. So most time patients will come to you like, I need my acne sorted out, then like within 2 weeks, they're not seeing changes, like, daktari, dawa ifanye kazi, they stop. So part of counseling is quite important. I think I have 2 more minutes. So just be aware common effects of using this medication: irritation. Topical retinoids, use them mostly at night because they're photosensitizers, and of course contraindicated in pregnancy because they're teratogenic. Yeah, I talked about antibiotics. So commonly, clindamycin is more available. This can be used. Benzyl peroxide also has a bactericidal effect. As I talked about earlier, better to be used in dual therapy. So treatment of acne, we do not do monotherapy, always do dual therapy. So you do your combination of either your topical retinoids and topical antibiotic, benzyl peroxide and topical retinoids, always do dual therapy. We do not do monotherapy unless you're doing maintenance treatment. So basically this is just to avoid resistance, bacterial resistance. Systemic antibiotics. Choice of systemic antibiotics is the tetracycline antibiotics. This gives a good anti-inflammatory action. So mostly do the doxycycline, minocyclines. This work quite well. In patients, unfortunately, who may have any resistance or maybe some side effect to all this medication, you can choose erythromycin or azithromycin. The macrolides also work quite well. Other treatment is hormonal treatment. Hormonal control. So mostly we can use the anti-androgens. So mostly especially in female patients, we can give combined oral contraceptives Spironolactone also has been known to be used as an anti-androgen and also glucocorticosteroids. So these are patients who have recurrent acne, rather are not responding to the normal treatment that you may give. So other than that, in terms of systemic treatment, this is our magic bullet. Usually what we get is what we use is isotretinoin, which is an oral medication. So this is mainly reserved for treatment for severe acne. So patients will come to you with maybe mild acne. I'd encourage you not to start using isotretinoin. So basically just reserve it for more severe, for more severe cases of acne. So we'll start at, usually start at 0.5 milligrams, then you can slowly adjust to till 1 milligram per kg. Of course, you need to do your baselines. I'm seeing my time is up, so let me wind up. So isotretinoin, as you know, is teratogenic. So patients must come with a negative pregnancy test, and you need to be monitoring. So they have to be also on hormonal, some birth control, because some people will tell you, no, I'm not pregnant, and things like that. So unfortunately, if she gets pregnant, you might need to make some tough decisions, which they might not be ready. So don't trust them telling you, like, patient like, no, I'm also on my periods and things. No, I'm like, I only need a pregnancy test. That's the only thing I understand, yeah, because it could land you in trouble. But anyways, so just be keen to note that. As I talked about effects, teratogenic, most common effect, you need to let patients know they can get extreme drying, especially of the lips and things like that. So you need to add additional moisturizers. Another thing a bit, in some patients it may be noted that rather few reports have been noted that isotretinoin can cause some mood disorders. In a few cases, apparently it's been shown to have some suicidal ideations, but this is still an ongoing theory, because the thing is, acne on its own, most of the patients have a low self-esteem and things like that, but this is still an ongoing thing. But just of note is that acne patients will need possibly also psychological support, apart from just the oral and topical treatments you're giving them. So these are additional treatments that you may give. Comidomol removal, chemical pills also can be used, though you need to use them quite frequently and not long-lasting. Intralesional injections, as I talked about. For the large nodules that you get, as I talked about, you need to watch the dose. Higher doses, more side effects, atrophy, and things like that. So you need to be keen in noting that. I'll just go quickly through treatment. So some of the treatments that you may do, so patients with acne scars, there's a procedure called subcision. So this is the skin, you can see the atrophy of the skin. So in acne scarring, what you get is fibrous tissue. So these are procedures that you can do using a cannula to free the fibrous tissue. Once you remove the fibrous tissue, the skin comes up. So this can be easily done using a cannula. So to free, of course, sorry, you need to apply local anesthesia first. Of course, you don't do it directly on the patient. So they're about 30, 45 minutes, then you apply topical anesthesia, and these are some of the procedures you can do just in your clinical setup, subcision. Yeah. Other things that you can also do is microneedling, so this will also help with acne scarring and reduction of pigmentation. So these are devices like a pen that causes, yeah, my time is up. So yeah, thank you so much. So in summary, I'll leave you with this table. So basically, we have mild, moderate, severe acne. So for mild acne, as I talked about, the first part you look at, you just use the topical treatment. So for moderate acne, you can do topical treatment. As I said, topical, you always do dual therapy. Then you can add oral antibiotics. Your choice can range from tetracycline, doxycycline, minocycline, and the rest. For nodular acne, of course, if those don't work, you need to use your systemic isotretinoin and many other additional therapies. The talk was, I hope you've learned a thing or two. I tried really summarizing everything in. Good. Yeah, thank you very much. Shukran.
Thank you very much, Dr. I think this is very interesting. Now we will give the audience opportunity to ask questions. They're very, very common happenings within our community. Can we ask the panelists to come forward kindly?
We'll take 3 quick questions, one for each speaker. Make it brief, precise. Just to tell you, these speakers will be with us here today and tomorrow. You can interact with them and ask them questions as you interact with them during breaks.
Anyone with a question? Yeah. Oh, no. There.
Assalamu alaikum. My questions are. Assalamu alaikum.
Waalaikum salam.
My question is upon management of H. pylori. Daktari, is there any role we have with antacids and the management of H. pylori? Kindly.
Good, so thanks for the question. Antacids, no, not really. They don't have any role to play with H. pylori eradication. They do have a role to play with dyspepsia, your gastritis, your peptic ulcer disease, etc. But H. pylori, no.
Can we take several questions and then we can...
So we'll take two more questions. One of the questions is written down here. What's your take on the new kits with clarithromycin, domperidone, and esomeprazole? You'll answer that. I've not seen that. One more question.
Yeah.
You introduce yourself.
Assalamu alaikum. My question is to Dr. Rashid. You mentioned that these patients came, all of them came very late. From your assessment, what is the cause of this late referral? Is patient's hesitancy or clinicians referring late?
My name is Abu Bakr. I'm a general surgeon. I also do endoscopies. My question is, can you use stool antigen to monitor for H. pylori positive that you picked on endoscopy? Because we find these patients that they're stool negative, antigen negative. You do endoscopy, they turn out positive, you start the kit, then you're really hesitant to go for endoscopy. Can you use stool antigen?
Thank you. Those are three questions. Can we answer and then we get some more? Good stuff, Doctor.
Okay, good. So yeah, I'll start with the question which was asked verbally. Yeah, that becomes a bit of a dilemma. I've had it as well in my time. Perhaps what I tend to do is I tend to probably repeat an endoscopy and get samples for histology again. If I've had a confounding situation where the stool is negative, but I've picked it up on histology. But might not be excellent science because sometimes the stains we do, you can stain dead bacteria. So it's a bit of a tricky situation, to be honest. But I think the stool antigen is very, very, as close to as accurate as you can get. So I usually tend to err on the side of the stool antigen as opposed to the histological, the stains of the H. pylori. Yeah. And then the final one here about amoxicillin, clarithromycin, and basically kits which contain other elements in addition. In particular, they were asking about domperidone. Very good question. I use other medications as adjuncts to my therapy. Especially with clarithromycin, the side effects of bloating and nausea are quite terrible. So yes, addition of domperidone for me is almost standard in all my prescriptions when I use clarithromycin-based regimes. So that's a very, very good question, yes. So I do add domperidone most of the time, or emetino, or any of the other, ondansetron, or any of the other antiemetics. But domperidone tends to work better because it reduces bloating together as also giving the effects of anti-MSs.
Thank you, Dr. Shaush, for your question. What I've observed, it's a combination of factors. One is failure of clinicians to recognize the disease early. So that means that they're referred late. And secondly is there is also an element of most patients being scared to intervene when they can still walk, which is a very wrong perception because the disease is progressive. So its natural history has been studied that it just worsens with time. So by the time they agree to surgery, most of them are on wheelchairs, they can hardly walk. And at that point, you cannot convert a patient who's on a wheelchair to normal ambulation. The best you can do is maybe ambulation using a walker. So it's a combination of factors. Yeah, thank you.
Assalamu alaikum. Thank you very much for the excellent presentation and the excellent work you are doing. I just had one comment that, I mean, much as the diagnosis clinically is quite obvious on clinical signs, I think one group of patients to be very careful about are older people with diabetes, especially those who have had diabetes for many years. They may not have the brisk reflexes and the other, signs, and yet they have a cervical, symptomatic cervical myelopathy which needs intervention. So that's one group of patients to have a lower threshold to scan. The other thing is when somebody is not walking, there's a tendency to either X-ray or scan the low back and forget about the rest of the spine, and that's a common error that we see in this situation. If you'll allow me, I'll make one comment about I'm not a gastroenterologist, as you know, but the issue of combining clarithromycin and domperidone or ondansetron, the one caution I would make, and I've seen this in practice with several drugs, is the possibility of QT prolongation. So that is something to be, and that is a problem which is reported in the Parkinson's literature for domperidone, where we would sometimes use it for the nausea-associated levodopa. So I think that's something to always be a little bit careful about and consider an ECG and things. Thank you.
Thank you. Dr. Keng, you talked about H. pylori in stool is one of the most commonly prescribed tests. What do we do when a patient comes to our clinic, the test is positive, but the patient is asymptomatic? Do we treat all H. pylori? If we leave it alone, is there a risk of further complications in the future?
Yeah, so the issue of H. pylori, So the rule now is in our population, like I said, one, don't look for it if you don't have to look for it. If you do look for it, you're by law, you should now go ahead and treat it, unfortunately. So even if the patient is asymptomatic and they've passed through your hands, you must treat it, because you might be held liable in 50, 60 years when they might unfortunately get a cancer of the stomach. That's the unfortunate part of it. So if you do go ahead to start looking for it, you're doomed. You'll be stuck with the patient, and you must treat the patient. Yeah.
Just to add on what Dr. Juzar Hooker said, it's very important that many times I get patients who have complete loss of power, waist down, with lumbosacral MRIs, which are essentially useless. Yeah, that's a very important point. If a patient has complete loss of power in both the lower limbs, it's better you image the thoracic or cervical spine. Imaging the lumbosacral spine adds no value. Yeah.
Thank you so much. I think that was very, very educative. Can we give a round of applause to our presenters? Sorry, we don't have many. We are 1 hour and some minutes behind schedule. And before I hand over, may I recognize the CEO of Jomo Kenyatta University College, Mr. Dagane. Karibu. And we thank mkono kidogo watu wakuje. Asante. Thank you. Thank you very much. That was very, very educative and very interactive, and we sincerely appreciate. Let me return back to Dr. Malim.
Shukran, jazakallah khair. One round of applause for the speakers. One round of applause for our humble moderator. So I feel very jealous today because I'm just reading bios. Hope one day someone will read my profile. So the next person I'm introducing is Dr. Omar Tayari. Dr. Omar Tayari traveled from UK specifically to attend this conference. Can we give a round of applause for him? So Dr. Omar Tayari is a sports and exercise medicine physician in the Institute of Naval Medicine in the United Kingdom. He's the clinical lead in the Tri-Service Illness Clinic at the INM, which manages patients from the UK Army, Royal Navy, Royal Air Force, and the Royal Marine. He has a professional interest in exercise medicine, extreme physiology, and performance in extreme environments, sharing this passion through teaching medical colleagues across the UK defense. Omar has been instrumental in the process of writing and amending the current heat illness-related policies with the aim of improving the safety of the UK military service personnel in training and operation. He is therefore considered to be the UK defense subject matter expert in heat-related illness, providing guidance for the return to duty of soldiers following heat illness. He is very keen on professional development and intercollegiate collaboration. In his free time, Omar enjoys traveling to remote locations abroadly, mainly in the tropical, where he likes running, hiking, and going on road trips. Can we have a round of applause for Dr. Omar Tayari?
Thank you. Very kind. Very, very kind. So one of my key moments today is the pride of attending this conference. I've always wanted to attend it, but because of the time, I'm not normally available to attend. So thank you, Dr. Nabila, for tracking me down and making sure that I've attended. So my name is Omar, and like some of the other speakers, I also grew up in Kongowea. So it means if you want your children to do better in life, raise them in Kongowea. It's a good step. And the other privilege is standing here in front of you as a boy who grew up in Mombasa, Kongowea, leading the only service in the United Kingdom that does what we do there, and being recognized as the UK defenses expert in that. You know, things are possible. Anything can happen. I've got the privilege of hosting this panel of 5 very distinguished speakers, and we're going to talk about breaking barriers. So breaking barriers in non-communicable diseases, such a big topic, but we'll try, hopefully, in the next hour to try and break it down into bits and pieces, chunks that you can take away with you that will be beneficial. Essentially, what is NCDs? NCDs, chronic conditions, normally has a long trajectory of progression. Treatment may be a bit difficult, and complications may be even more difficult to take care of. Mainly comes from interaction between genetics, physiology, the environment, and behavior. And that's what we'll try today to bring together. So my panelists, please, if you don't mind to come up front. We've got 2 nutritionists, both named Esha. So again, another privilege to host 2 Eshas on the same platform. We also have Dr. Gamar, who's a physician, and we've got an oncologist. Happy to see you, because I think you're running late. And we've got a psychiatrist. So the panelists will introduce themselves as they start talking. I'll just grab that. But the key thing here is to allow them to speak about their subjects. Where I come in here, this panel is very, very interesting because everyone has something to give back. So from my point of view, as a sports and exercise medicine physician, my responsibility is making people active. So getting people physically fit. One of the clinics that I run for the Royal Navy is a physical fitness. Explains why I look like this, because you cannot tell a soldier to be fit if you don't look it. And physical activity has been known to be one of the key measures that you can undertake to either for primary or secondary prevention for non-communicable diseases and other diseases. So without much further ado, I want to introduce 2 speakers who are going to start speaking today. And that is Esha, who is a nutritionist and coordinator for Mombasa County's NCD program. And we have Dr. Gamar. Dr. Gamar is very special to me in the sense that she treated somebody who was very close to my family. And I really appreciate that. Thank you. So yeah, over to you. And you'll take us through risk factors. You'll take us through NCDs. What is it? What are the common ones that we see? And I think, Esha, you'll also take us through the, what the county has done to try and mitigate this or to try and improve it. So over to you. Thank you.
Assalamu alaikum. So the reason why we chose this panel actually is because non-communicable diseases are becoming a burden, and 80% of the non-communicable diseases in the world lie in the low middle income countries, and we are part of that. We have that burden to bear, and we have to think about how to overcome this burden. So 4 of the major non-communicable diseases that we're dealing with is diabetes, cardiovascular diseases, obstructive lung disease, COPD, and cancer. So it is a burden because also it comes up with a lot of mortality. 1 in 4, among the global mortalities that we have, at least 30% of them lie within our territory. And that is why we chose this panel. So the risk factors associated with cardiovascular diseases in the low middle income countries and in Kenya as well are the common risk factors, which are obesity, which we have 27% prevalence in Kenya. Other risk factors that we have are tobacco use, and alcohol use, and sedentary lifestyle. Of course, Dr. Tayari will speak more on that in terms of exercise and active lifestyle to try and reduce this burden. So among the cardiovascular diseases, I'll narrow down to hypertension. Kenya has a high burden of hypertension among the cardiovascular diseases. I've narrowed down to hypertension. We have 27% prevalence, and out of the 27%, about maybe 8 to 10% are actually on treatment, and that's alarming and concerning. So I'll hand over to Esha to tell us what are the strategies that the county has to overcome this burden.
Assalamu alaikum. First of all, I would like to thank God to give me this opportunity to be able to share whatever we have. But before I go to the intervention, I think I will talk about the barriers. And as I'm talking about the barriers, I cannot say they are barriers which are affecting Muslims, but these are barriers which are affecting the community in accessing services for NCDs. Why I'm saying that? Because we've not conducted any survey, but because I am a Muslim and a member of the community, I can confidently say that these barriers are affecting Muslims. Otherwise, I don't have any statistics to prove that. One of the barriers is low awareness of availability of services. Our people, our Muslim community, they are not aware that the public health facilities offer services for NCDs like diabetes, hypertension, cancer screening. Most of them are not aware. So they think that these services are only sourced from the private. Another is low awareness of importance. For those ones who are aware, they think it's not important. Why should I go screen myself? Why should I know about whether I'm diabetic or not? Why should I know whether I have cancer or not? So there's that. There's also fear for unknown. Among the Muslim community is people will say, why should I go look for a problem which I don't even know that I have it? It's like I'm looking for problems. There's the negative attitude, where we think that, why should I do it? And we like normalizing. It's like somebody has a headache, frequent headache, this is normal. She's inherited it from the father. They always have a headache. There's denial. Some people are already presenting with symptoms, but still they're in denial and they don't want to go and seek services in our facilities. There's stigma. Some people think that, okay, if I go and I'm known to be having cancer, what will people think about me? Or if I'm diabetic. There's a refusal. There are people who are already sick and they don't want to come to the facilities. Well, we also have socio-cultural barriers, like religious barriers, where most of us would, as women, we would not allow men to examine us, like, for example, ladies who walk into our facilities and the healthcare provider is a man, and she would not let a man examine the breast or do a cervical cancer screening, because we are not allowed to expose ourselves to men. We have the Mwenye syndrome. Mwenye syndrome is where the woman cannot make a decision. Okay, you educate a woman that you have to be screened, but this woman still feels that I have to consult my husband, I have to consult my seniors at home, and she cannot make decision. We have beliefs in witchcraft, which is still existing so much. We take herbal medicine and we come to the facilities when it is too late. We also have resistance to change. As much as we are educated, as much as we are told that unhealthy dietary practices are not good for us, but we are resisting. Even among ourselves who are doctors and nutritionists, we are still resistant to change because we are always finding ourselves taking very unhealthy diet. We also have economical barriers where the cost of treatment is high and somebody feels like, why should I go? I have to pay for the mammogram, maybe, for example. I have to pay for blood sugar. We also have an issue of time spent where somebody feels that, why should I go for treatment, or why should I go for screening? Instead, why don't I go to my small kibarua or my biashara so that I can earn something? We have also fear of financial burden. Some of the people feel that once I go and I'm found to be sick, this financial burden will be too much for my family, so I cannot do this. So these are among the things we have. And interventions, we have interventions which are divided. We have interventions for the non-communicable disease. And the interventions are divided into three. We have the first category for interventions is the preventive. The preventive, we have education, we have screening and referral, we have health promotion services, we have units in the Mombasa County which are very aggressive, like, for example, the NCD unit, which does screening at the community level during outreaches. We do NCD screening as routine services in our health facilities. We do NCD screening during commemoration. We also have another unit like the RH, the reproductive health, which is very active in screening for cervical cancer and breast. We also have the health promotion unit, which is very active in creating awareness. And we also have the nutrition unit, which is very, very vibrant in passing information across the community about proper eating habits. And then the second category for intervention is treatment and management. We have comprehensive care clinics for diabetes. This is a center of excellence at Coast General Hospital, which offers all the services in regard to diabetes, hypertension. We have a comprehensive treatment center for cancers. We have renal units. We have a cardiology unit where all the services are offered. And these clinics are not only at Coast General Hospital, but we also have them in level 4, but like the diabetic services and the hypertension. Those are the sub-county hospitals. We have them in level 3, that is the health centers, and we have them in level 2, that is the dispensaries, where a patient will walk in and walk out with treatment for the non-communicable disease. Then we have the post-care. The post-care is, at the moment, we are actively trying to build the capacity of our hospital to be able to start palliative care services. We have, but they're quite weak. But now we are aggressively going into that. And also for follow-up of our patients. Once we have enrolled them in our clinics for treatment, they are being followed up. Right now, under the program of universal healthcare, which has just been rolled out, our healthcare promoters, those are the volunteers, formerly, they are now called promoters because they're being paid a small stipend. They are equipped with blood sugar machines and blood glucose and blood pressure machines. So they're able to follow up our diabetes and hypertension patients who are not due for clinic. They're doing well. They just come for top-up of medicine, but they're being followed up at home. So this one is already taken off. Whatever there are interventions, there are also challenges. We have quite a number of challenges to address these issues. One of the challenges is inadequate staff in our health facilities. Our staff are quite constrained. One nurse can find herself providing all the services for clinician, is also dispensing medicines. We also have inadequate capacity. Sometimes a client may walk in a public hospital and the healthcare provider who is there has not been trained on cervical cancer screening. Another challenge is in infrastructure. Our health facilities are constrained. I'm sorry, I'm taking too long. Infrastructure, our health facilities are very small. They are squeezed such that there's no privacy. Sometimes as much as you want to do the screening, you want to do the counseling, but there's no space. Another problem is poor referral system. You get a client, you refer a client from one level to another, maybe from a dispensary to a health center or to a sub-county facility, but the issue of the process of making sure that this patient has reached where you have referred is quite cumbersome because of resources. So the patient has just to decide whether to go or not. Another challenge is breakdown of machine, or sometimes we don't have the commodities, we don't have the diagnostic materials because of resources. There's delayed treatment because of long queues. We have a lack of integration. Sometimes when it is cancer, it is only cancer. When it is diabetes, it is only diabetes. But as much as it is happening, we are really trying to integrate all the services. We also have issues with data quality. So we are addressing this. We also have an issue with, we don't have a very strong multi-sectoral platform where we can address issues from different sides. Like, for example, chemicals which are contributing to cancers, maybe issues of like other carcinogens. There are issues which are not under Ministry of Health, but we have to come together as different sectors and departments to discuss this. So this one is not very strong. But all in all, we are trying our best to implement. We have a county action plan for every NCD, and we are trying to implement this action plan. Our biggest challenge is resources. Okay, I'm sorry we don't have resources, but as a recommendation for the barriers, I recommend
we'll come back to the recommendations, because we've talked about the challenges and we'll look at the opportunities, and I think that's where you'll come and hit hard on the recommendation. Yes, hard hitting is towards the end. You bring your enemy close to you and then you hit them hard at the end so that the fight is not very long. So next we're going to hear from consultant psychiatrist, Dr. Rajab Saddam, who is part of the Chiromo Hospital Group in Mombasa. And the interesting thing here is the interplay. So there is a bit of an interplay between mental health and non-communicable diseases, how people approach these things in terms of the patients and even the clinicians, how they approach some of these issues. So please, you've got about 8 minutes to give us what you have. Thank you.
Thank you, Omar. Assalamu alaikum. My name is Rajab. Actually, for me, it's the journey of mental health being integrated to the NCDs. It is still being thought as an afterthought. Not just here, even when the UN General Assembly was discussing these things initially, mental health was an appendix. Through no fault of her own, my colleague has talked about 4 NCDs, because that is how we are conditioned. Mental health is an afterthought, but it is a pebble in our shoes that will not go away. you can treat every other thing, but if you ignore the mental health of your patient, then no matter what good medication you give them for diabetes, no matter what treatment plan you have for oncology, no matter what plan you have for respiratory illnesses, is that things will not work. 60% of patients with chronic illnesses suffer mental illness. While on the other side, a patient can have mental illness and not have the other 4 NCDs. So you can see the burden of mental health to the patient and, I dare say, to the caregivers. The level of anxiety and depression, which is actually the commonest mental burden. It is not psychosis. And that brings me maybe to the next point of stigma. That even we as medical professionals, sometimes when we talk about mental illness, then the first thing that comes to mind is psychosis and people going mad. But the majority of patients we see have depression and anxiety, and they look as awesome as we are here, just struggling quietly. So the interplay between these illnesses is very key, and anyone who is a champion for any non-communicable disease has no option but to also be a champion for mental health. And to learn to screen, to learn to communicate to the patient and to the other caregivers, to look out and what to look out for. I think we can pick it up from there.
Yes, thank you. So what's your perspective on the impact of mental health in the Muslim community? What are you seeing in your practice?
The impact is actually very huge. I'm privileged to oversee a facility that is just 1.5 years old in Mombasa, the only purely private psychiatric hospital. We started with maybe the first month seeing less than 20 patients. Right now, the traffic is at 300 as an outpatient clinic. It just shows you the need that is there, and it just shows that we have not even reached enough, because the burden is real, the stigma is still there. We are struggling both with clinicians and families. Some have been told, but as we've been told, the old ways to try and unlearn is becoming a problem. And depression, for example, is very costly to the economy. To the world economy, up to $1 trillion per year. It is going to be the leading cause of disability at the workplace, over passing all these others, physical disabilities. So the burden is real. Mental health is not, or mental illnesses are not something to be overlooked, but actually something that should be a high index of suspicion for any clinician at any level of point of care, I would say.
Thank you. You've mentioned clinician there, and I'll just pick you on this, just to give one word on the human resource available to you and available to, for example, the wider Muslim population in regard to mental health. How does that look like?
The human resource is poor. That is the long and short of it. The truth is we are less than 10 psychiatrists in Mombasa, and I think before last year there were only 3. It's just that there was a surge when myself and my colleagues did finish school. For a long time, it has been overseen by psychiatric nurses and psychiatric clinical officers who have tried their best. And what we are doing right now is trying capacity building, going back to the same pool that is there, and now even the general clinicians, to just make them know what are the common things to look out for, so that we can all actually play our part in early detection.
Okay, that's a nice way to end that bit, because early detection is probably one thing that oncologists would probably want to be able to do for most patients. So I have the privilege of introducing Dr. Abdurrahman Aboud, who's a consultant oncologist at, in my day, it used to be Coast General Provincial, but now I hear it's Coast General Teaching and referral hospital. So welcome, Dr. for this, into this session. What we really want to know is the status of cancer in Kenya. You know, how does it look like? And extend that into the Muslim community. Where are we? What are we looking at? How big is that beast? Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I will touch a bit on the global burden as compared to our local data. As my colleagues have introduced this as the second killer in NCD as cancer. So whenever we look at our local data, we want to compare ourselves with the other regions. In Kenya, we are considered among the low and middle income countries. So when we look at the global data in the most reliable database of GlobalCan, which they produced in 2020, we had an estimate of 19 million cases of cancer diagnosed in the time, in the whole world. And using the algorithms, we expect, if nothing is done, to increase in the prevalence of malignancies to 28 million. And why I had to mention these figures is we want to know where we are as a country and as a community, a Muslim community. So when we looked at the distribution of the cases of malignancies, we found that we had 2/3 of cancers were diagnosed in low and middle income countries. Sorry, a third. And 2/3 were diagnosed in the high income countries. And I want to relate this to the effect on the population. So we did some analysis, and we found that most of the deaths, which is 2/3 of the deaths, occur in low and middle income countries. So we wanted to know why. So we compared the United States of America, which considers a high economic zone, and then we compared with African countries like South Africa, and ourselves, Kenya. And we found that the trend is the same. We had a lot of cancer diagnosed in Europe and North America, and very few diagnosed in Africa, yet the mortality is inverse. We had a higher mortality in Africa compared to the... So not to take much of our time, so we had our own data from Coast General, which is not yet analyzed, but we wanted to know the reason as to why we have low cases, but yet the mortality is too high. We took data from January 2023 to last month, October, and we wanted to see what is the trend. So we had approximately 160 new cases to 210 per month being diagnosed at Coast General only, let alone the other private facilities like Cancer Center of Excellence Sinyali, Aga Khan, Premier, and the like. So once we got that number, then we went further and analyzed the data as what caused the mortality to be high in our setup. And we realized majority of patients, more than 50%, presented at our clinics at least stage 3. Then followed by stage 4 patients, then stage 2, then stage 1 patients. So in this trend that we have higher burden and the mortality is, the cancer deaths are going higher, so we wanted to know exactly what are the challenges, what are the causes as to why we have such a trend. So we did a study, me and my colleague, last year at Coast General. We did a cross-sectional study where we were doing it was a screening. So we had 250 patients. And we realized less than 50% of patients who attended the screening were native from the coastal region. Less than 50%. More than 50 were all from other places. So this gives us, stimulates our thinking and as to why do we have low turn-up in screening. So among the things that we checked as the reason as to why there was a low turn-up, only 3% of the patients, only like 3% of the patients, specifically to cervical cancer, had limit access. Yani they could not access. They had limitation in accessing the screening and the preventive mechanisms. And out of the 3%, the access was the age limit, only the age limit. And around 30% of patients, around 30% of people who attended on questionnaires asked why do we have low acceptance of vaccines such as HPV. Approximately 48% shy away because of the side effects, the myths of the vaccines. And here we are here today to clarify the bits, to answer the questions regarding the vaccines, and now let's on another level. Our colleague from Eldoret is called Professor Chite. Also did his own study on presentation of patients. Sorry, not even presentation. The time it takes for a patient before being diagnosed of malignancy. And he found out we had a delay of diagnosis between 2 to 5 years. That was in Eldoret by Prof. Chite. So, and this was contributed to lack of human resource. So we had only low cadre health cares who could not be able to diagnose or refer adequately. And just to add on that, so we have, in the era of AI, artificial intelligence, we have a system called Choir AI. For example, in Kenya, we look at the 5 commonest cancers. In Kenya, we have breast cancer, cervical cancer, esophageal cancer, colorectal. So if you look, when we compare the data we have locally with the data globally, lung malignancies, they were considered number 2 commonest cancers in the world. As of today, I think it's even number 1, even it's beating the breast cancer. So the question is, why don't we have lung cancer diagnosed in our area, in our country, and yet the other side, and people do smoke and all these other risk factors? So we realized that due to that delay in diagnosis, X-rays are sent, given antibiotics. So we have an AI program which works on digital platforms like digital X-ray. One which is on pilot program right now in Kammp in Eldoret is called Choir AI. What it does, once you do your chest X-ray, you plug in your software, and it gives you the most likely diagnosis and the most likely next step of care. So with that, we hope that most patients with chronic cough, weight loss, they're not misdiagnosed as TB. At least when we have such AI. And just to loud on this point, we had one of our young boys from Mombasa who just graduated in Malaysia in software engineering. He's called Salim Kadedina. He developed a program, an AI program, which is used on digital mammography, where it gives you the probability that one has a malignancy. And that definitely helps in picking up cancers more. Yeah. And just to add on our screening modalities, we are taking leaps, good steps in screening. Currently, we're having a very interesting technology in screening, one of which is called tomosynthesis. Currently, we use mostly a 2D mammography, and even if you have 3D, now the tomosynthesis, what it does, it gives you the slices of the breast to show you the three-dimensional from where your lesion is. And just to mention, in the UK, in the NHS, as we speak, that AI program is used, but not routinely for screening. And tomosynthesis, it's also part of the NHS recommendations, but not to be used routinely to screen our patients.
Yeah, there's been a lot of talk about AI, and we'll come back to that, because that's you're driving into the opportunities that are existing in this area. Last but not least, and it's not by chance that we've left this for last, but we're going to hear from our sister Esha Adam, who's a clinical dietitian based in Kilifi, and from what she's going to talk about, the nutritional interventions or nutritional strategies for management of kidney disease, I believe, and cancer patients. So it ties in quite nicely from the talk from Doc. So welcome, Karib Sana.
Assalamu alaikum wa rahmatullahi wa barakatuh. Okay, from the discussion that have been going on, you'll find that in all this talk, we have something called the reactive oxidation species in our body that actually contributes to what my sister said about hypertension, because these species actually tend to work on the protein molecules, the lipid molecules in the body, that when it works in the lipids component, in the arteries is going to lead to something called atherosclerosis. So I'm starting at a point that where we all understand, before I bring my nutrition concept, the same oxidative stress that we're having in our body is one of the major factors that actually contributes to the cytokinins, which will lead to carcinogenic components. And it is very essential when a diet is being brought at this point, we actually main focus to reduce the oxidative stress in the body and remove the free radicals. Now, at what point, let me start with the prevention aspect. Whether it is, because it's of the general population, it doesn't matter whether you're a Muslim or non-Muslim, but now here I'll be biased because we are all Muslims. You'll find that, can we just have a preview of our diet as Muslims? In most cases, you'll find that we are having a lot of fried foods at our table, whether breakfast, whether lunch, whether supper. And this aspect is actually contributing to the oxidative stress that you're finding in our body, predominantly predisposing everyone in this room to actually having any of the non-communicable diseases. Now, at this aspect, for us, in order to change the behavior and how we preview how this food actually have an effect, is that the first step, we need to incorporate vegetables into our diet. Why vegetables? Whether green leafy vegetables or the other ones we know, like capsicum, red bells, tomatoes in terms of salads. We need to incorporate in our diet because, one, they come up with something we call polyphenols that actually tend to help to reduce the oxidative stress in our body, reducing the effect and actually make us a bit, I'll say, safe, in quotes. Then at the same time, when actually we are taking the, alhamdulillah, most Muslim dishes, they actually tend to have a lot of spices and herbs, which actually contribute in terms of tannins, in terms of flavonoids, and also the polyphenols to actually reduce the oxidative stress that is actually going around in our bodies. So secondly, we also need to actually look at the amount of carbohydrates that you are consuming. For example, we say like somebody will actually put a plate of almost 5 chapatis or 3 or 4 servings of rice. When you take this, and unfortunately, if you're not an active person, what happens to your body? it's actually going to increase the oxidation, and that is how we actually end up getting obesity that will later lead and predispose you to diabetic or the actual hypertension that Dr. Kamara was talking about. So another aspect that I want to bring to your attention is actually the amounts of proteins that we consume. I remember when I was young, most of the time we used to eat a quarter of meat, and you find that it's served among 5 people. But today I'm in a position that I have the power. I choose what I want to eat because I have the bargaining power of choice. But unfortunately, the choices I'm making is actually compensating for what I missed out as a childhood. And I believe everyone in this room, we have actually reached at that juncture. Maybe you are actually in the process of you've already crossed over, but you'll find that when you're having a purchasing power, our choices of food, if not well directed, will actually predispose us to these diseases. What do I mean? If you're young, when you're not allowed to take sausages, whether especially halal sausages, when you're growing up, like even today you ask a child, what do you want when you get out? They'll tell you chips, chicken, sausage, or pizzas. So you can imagine if this trend continues for 5 years, you'll starting to see physiological change up of this child, and actually later, now we're seeing early cases of obesity among the young adolescents and all that. So in short, what I'm trying to say, in order to actually be able to curb the non-communicable disease, 1, increase the amount of vegetables that we incorporate in our foods, especially for supper and lunch. This aspect of people missing meals is not attributing to what as a target of losing weight, because there's a point that every part of our body needs to be metabolized, and we need one nutrient after the other. So when you miss, you're pushing your body to a way that is going to try and compensate for the nutrients that are being lost, and to some extent predisposing you to something else. So when I go to, I've talked about prevention, and now I'm going to talk about the medical therapeutic nutrition. This is actually designed for illnesses, especially for diabetic patients, for renal patients, for cancer patients, and you're also having hypertension patients. Like if I'm dealing with a patient who has the renal patient, one predominant diet we will actually align them, but this one will depend on their UECs. If they have high levels of calcium, we'll make sure and ensure that the food they're going to consume, it is actually specifically designed to remove any form of their potassium levels. The same applies to either sodium or phosphate, and at times also, if they're depleted or not having, they're having calcium problems, they'll come with numbness, pains, and all that. So on that note, whether it's all the non-communicable diseases, it's very essential to be very keen with nutrition. As my brother from the psychiatrist, because in order for us to have effective management and treatment, it is very important to ensure diet and psychosocial and psycho well-being of a patient is very important for their recovery and also to reduce the prognosis of the disease. Thank you very much.
Thank you. We've overrun a little bit. So what we'll do is we'll go straight into a few questions. And the first question is to Dr. Kamar. Could you briefly, in 30 seconds, talk us through the risk stratification? So just a clear, precise risk stratification for cardiovascular diseases, please. Thank you.
So a take-home message in regards to cardiovascular disease risk screening. I would like it to be at least a common practice among our colleagues who are interacting with patients who are hypertensive, diabetic, is to actually download an application on cardiovascular risk stratification or risk scoring. You can use the WHO risk scores, the charts. It's applicable even in areas where you don't have a lipid profile. Risk stratify the patients, those who score above 20% based on the charts which are available online, start them on a statin. If you're using the ASCVD, the American risk scoring, which is available on your Google Play or those who are using Apple, you can download that. Use the ASCVD risk score to score your patients. If they score more than 7.5%, start them on statins. For those who are hypertensive and at least hypertensive and diabetic patients. Automatically for your diabetic patients, start them on a statin. The type 2 diabetics, immediately you diagnose them if they are above age of 40. That would be my take-home message for prevention of cardiovascular complications among your hypertensive diabetic patients.
Thank you. Thanks for that. Esha, just a quick 20, 30 seconds on the translation of all of these nice things that you're doing within the county. But what does it mean to the lady who's preparing viazi or the gentleman who never went to school? How do they get this information of all these nice things that you're doing in 30 seconds?
We do health education through the local FMs, through Radio Rahman, Radio Salam. We also pass this information through our health clinics. We also pass information in the community through the community health promoters. But all in all, I think it is very necessary at this point, the Muslim organization to come up with a very vibrant health promotion unit, which will do advocacy, awareness creation, and mobilization of our community members. This unit should be able to penetrate the Muslim community so that they can come out and seek these services.
Thank you. You have something to say, Gama?
Yes, one statement. I want to add on to what Asha said. Actually, Kammp has been very active in this. We are actually addressing this problem. Dr. Jalab has been active in public awareness, and the Nairobi team has also been active in organizing medical camps for screening of these diseases. Thank you.
Thank you. Just going to Dr. Rajab, and what's your experience on the MDT approach, so multidisciplinary approach to mental health? Because you clearly, we've seen, it cuts across everywhere. So how do you start to bring that into play as an opportunity, going with the topic of the day? Thank you.
Thank you. I think it cannot be overemphasized how important it is to work as a team, starting from the clinical officer, as we are saying, from the nurses, our other specialty consultants, because most of the time these patients they present with physical illnesses first, sometimes before it's actually mental illness, or the physical illness takes a toll. So it has been very important for us to work hand in hand. And also sometimes when they come and you know very well that there is a comorbid condition, then you have to invite the appropriate physician or consultant so that they can help with the care. I think we are now at a level where it will be ignorant for anyone to attempt to handle everything. So we can only encourage each other to ensure that you pass on the baton anytime you know you need some help in an area where your expertise is a bit not up to date.
Yeah, thank you. And speaking of areas of expertise, I'm just going to add something from my point of view. So in sports and exercise medicine, so one of the key problems for medical doctors is how do you prescribe exercise? How are you going to tell your patient this is what you're supposed to do? So the simple answer is if you look at the talk test, your ability to breathe and talk at the same time is your level of intensity of exercise. So if you can talk, like right now I can talk, I can speak in full sentences, it means I'm working at a very low intensity. Moderate intensity is where if you're doing something, an exercise, so for example, you're walking really quickly, you're unable to talk in very long sentences. So that's a key feature that you can give your patient. This is what you need to do. Tembea haraka haraka mpaka uwe huwezi kuongea na mtu. And then high vigorous intensity exercises where you can hardly say anything. So when you're running, for example, you cannot talk to anyone when you're running. So when you're prescribing to your patient, you say to them, I would like you to do moderate intensity exercise for 30 to 60 minutes most days of the week, so that's 5 days in a week. Do that consistently. Nenda rudi nitachukua blood pressure yako tena nione kama ulifanya. They will do it because you'll bring them back to take the blood pressure. Okay, vigorous intensity is for the much younger people, so they can do that, playing football, all of that. So coming to you, Dr. Aboud, just a quick mention on, we talk about big research, we talk about, collecting data and AI, that's very big. The low-hanging fruits are things like audits. How many patients walked through? How many patients received that and that? Is this something that you think could be easily implemented? It does not require publication. You have an internal means of discussing this in grand rounds, things like that, encouraging young doctors to do that. Is that something that you would find beneficial and for the wider audience? Thank you.
Yes, we've looked into the as you said, locally what we can implement to reduce the burden. And we found that approximately 30% of malignancies are infection associated, and meaning that 30% of malignancies can be prevented if we eradicate such infections, HPV, hepatitis, and the most common, which was also compared in a big trial where they looked at the whites, blacks, Asian, non-Hispanic whites, it's dietary. And we found that by strictly abiding by the diet, which is recommended by the ASCO, we reduce the chances of having colorectal cancer by 45%.
Correct.
And breast cancer by at least 25%. And among the nutrition, she's already mentioned, we have cruciferous. And in your area of expertise, we need to sensitize young people in our areas that exercise is, as you said, moderate intensity. In our patients and our elderly patients, we recommend 150 minutes as per ASCO guidelines, 150 minutes per week. And sensitization.
Yes. Yeah, thank you. And finally to Esha, it's well and good to look at dietary and nutritional advice, but what do you find to be an issue in terms of the level of understanding? So if you tell somebody and you've designed for them a diet, how do you find the level of understanding of those people and their compliance to that? In 30 seconds, please.
Okay, from where I'm working, I'm actually dealing with the natives. But most of them actually tend to use the jive method. Majority who have not gone to school, it is easier for them to understand. And then if I get patients who are actually enlightened and they know what they do, I actually tell them. Then I request them to come back with a food diary, which we'll go through and see where the good things were done, where the neglection was, and now we revisit again, then we go through. Not leaving aside the ones who are not that illiterate, we also just try to have a recap of what they have going. Then in the process that you're doing the follow-up, the patient will actually confess and say, I forgot this or I did this. And from my experience of 8 years working as a dietitian is, when you just tell them and they go, there's no follow-up. For them, they actually feel they are cured. But if you now have this strict follow-up, it actually really helps. And now you'll be able to actually achieve your 50% of the diet. And after some time, we'll see that progression of either cancer or progression of the GFR is lowering in terms of the renal patients. And if the checkpoints for the blood sugar of diabetic, you'll actually find it is actually improving. And the HbA1c, if you're dealing with 9.6, after 3 months, you send them back, they'll come back with around 5.6 or even actually they tend to come with less than 6%.
Thank you.
Thank you very much.
Thank you. I think what we've talked about here today is quite wide. And you find that we are struggling to try and fit in everything to talk in this 1 hour. At this point, we'll take questions from the audience. We'll take 3 questions from the audience. If you've got more time, probably we'll do that. Make it short and sharp, and we'll try and respond short and sharply as well. Thank you.
Introduce yourself and ask a question and who you are addressing the question to.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Abdurrahman. My concern in regards to non-communicable diseases, management, prevention, and all that, we have to consider there's a factor that we have to consider, and that is poverty. It's one factor that is really pressing our society. All over, it's cutting across the Kenya, and now how things are moving day by day, and the economy of the country is getting worse. it becomes a burden to the patients, to like when purchasing drugs, in investigations and etc. So what are this is for Dr. Aisha obviously, what are some of the things that we can, as a county or as public health services and the authorities in charge, what are these projects or programs that we can bring in place to make sure these people are getting help? Because they come with the NHIF, they ask you, I have NHIF, I cannot get medication, so what is the use of this program? So these are the questions we always get. And most of the defaulters and most of the complications that we get is due to inability to purchase the drugs and get the treatment. Thank you.
Thank you. We'll take the second question. Thank you.
Assalamu alaikum. I'm proudly to say that I'm also one of the team Congoers. And my question is about NCDs and electromagnetic waves. Do they have any sort of relationship, more so the boosters which we see in some tall buildings of communication? Kindly shed light on me on that. By the way, I'm Mohammed Hamis, I'm a clinical officer. I have a degree in public health, currently doing my master's in public health from Pwani University. Pleasure to be here for the first time by there.
All right, last question. I'm from Takaungu. Yeah, anyway, thanks to all. I have a question for the dietitians. To what extent are you promoting intermittent fasting, you know, as a health intervention, particularly for Muslims, but there's also intermittent for non-Muslims? For the cancer screening, you know, what are you promoting for screening for CA, esophagus, and colorectal cancer? Since every time you hear it's breast and pap smears, right? And then what are the religious barriers that are hampering screening for NCDs among our Muslims? Over.
Thanks for those three wonderful questions. I'm just going to mention something along the lines of poverty. So poverty comes into play when you're wanting to intervene. So the person is already suffering a disease. My point of view, or the way that I see things, is you have to prevent that person from becoming a patient to begin with. And most of the interventions to prevent somebody from being a patient are free. For example, running is free, walking quickly is free, exercising is free. All of these things are free. So yes, the question of poverty comes into play, but that's when they're a patient. We're trying to prevent them from being patients. Thank you. Esha, there's a question for you.
Shukran. Okay. As Dr. has put it, prevention is better than cure and it is cheaper. And it is our responsibility to educate our community to take responsibility of their health, because afya yako, responsibility yako. Number one. Number two, about patients who cannot access medicine because the NHIF cards, okay, they have NHIF, but the medicines are not there in the hospital or other diagnostic services. We've just concluded as a county a framework on private-public collaboration. And this one will enable us comfortably to sign MOUs with private facilities so that when a patient is referred from the Coast General Hospital or from a public hospital can access services at a cheaper cost in a private hospital. So that is one way we are doing that. Secondly is we are also working very close with donors. And thirdly is
So to add on to the issue related to poverty, Novartis actually rolled out a study, and I think it was called Access, and they actually found that they were providing medications and trying to subsidize costs to less than $1 a month. And actually the patients, it was found within that study that patients were actually getting their medications from the private sector more than the public sector. So as much as we are thinking of poverty, we need to also be evidence-based and find whether there are really associations in regards to financial constraint and getting medications. As long as I think the most important point also is to actually discuss with your patient, empower them, let them know why you're giving them that treatment, and the compliance will be better.
Just to add on what we were just discussing is about the CEC speech today. It was clearly saying that the county is investing very heavily to make sure that these medicines, the commodities, the equipment are available in the hospital so that any patient walking in with NHIF does not miss any of this. So this is one of the interventions we have.
Thank you. I think the question of on electromagnetic waves, please just briefly, 10, 15 seconds, please.
In a few seconds, we had a trial in 2017, I think done in, it's an observation study done in India. It showed that by use of telephone had a positive correlation with the levels of TSH. Based on that, in Egypt, I left the study because for those who've been severally in Egypt, they'll find Muslim ladies, mashallah, they hold their phones on the hijab, fixed there, like it's their normal duty that they do everything. So based on that data, so they were doing research to see if there is increased incidence among the women who use mobile phones, which are always fixed during the day. So with that, we don't have concrete data, but kindly check on that, what I've just elaborated.
Thank you.
And the third question was still on my table?
No, so the next question is for the dietitians.
No, it was.
Yeah, there was one more question for you. Yeah,
sorry.
Yeah, right.
She's asked very good questions regarding what do we do. We only do screening for the breast cancer. Well, so breast and cervical is overemphasized because it's the number one and number two, both number one and number two incidence, number one and number two even in terms of mortality in Kenya though. So for esophageal malignancies and colorectal, they're number 3 and number 4 respectively. So for colorectal, we don't have a big campaign, but we emphasize patients based on American guidelines that any patient who is above 55 years should have either every year fecal occult blood test or immunofecal testing, or every 3 to 5 years colonoscopy. Anyone above 5 years. And for the esophagus, unfortunately, we don't have any screening that I know of, but in Nairobi Hospital, they've introduced recently, probably, I don't know, I heard about it like 2 weeks ago, they have endoesophageal ultrasounds for staging though, but not for screening.
Thank you. There was a question on the barriers. So I think I'll ask Dr. Rajab quickly. Barriers to screening. I know it's probably slightly beyond, but the psychological element to that, just briefly.
I think the barriers to screening is access to many people, especially for the 4 initial NCDs. The barriers to screening for mental health, I think, has been a lack of knowledge, because most of the screening tools are actually available and for free. I will actually share a link of what we do give to a lot of the places we go to give these sensitizations to. You can screen yourself for depression, for anxiety, for burnout, especially those of us at workplaces. 2 or 3 minutes and you're done, and you can do it every so often. So I think it's about making these things accessible. And for those, maybe trying to brainstorm of how cost-effective can the other screening measures be, but ultimately prevention, so that we don't even have to go to those cost-consuming methods, I would say.
Thank you. Finally, again, to Esha, and it's a question on intermittent fasting. Before you say something, I'll probably want to mention it because it's something that comes to my desk a few times. So military people who, for example, have become vegetarian or vegan, or Muslim soldiers serving in the UK military, how can they perform their duties? So these are interesting questions. And intermittent fasting has been found to be effective in certain population, but that's not in isolation. So intermittent fasting with increase in physical activity would normally be the way that I would approach it and emphasize.
Okay, intermediate fasting has been a facade for a long time, and intermediate fasting is very good for especially children with epilepsy, and it has been proven to work very effectively. And if it's a person who is looking actually to cut down weight, if you are, let's say, obese grade 4, in the first 3 months, you'll actually be told to do it, but as time goes by with active activity, as my brother said, and during that time, you are actually encouraged to fast between 10 to 14 hours, but not the extreme, which actually everyone wants to take. And then secondly, intermediate fasting, you do it aggressively only within the first 2 months, and then now you put your diet correctly, incorporated with other foods, so that not at any given time, it's just going to predispose you to a liver condition, especially the non-fatty acid liver cirrhosis. Thank you.
Ladies and gentlemen, brothers and sisters, I think we've overstayed our welcome here. It's a big topic, so I think we can be excused for extending the time. And it's your own fault for putting me here and putting this panel here. We have a lot to say. Thank you very much for listening. I hope that everyone has picked something that they will find useful to go with. And with that, I think, on behalf of the panelists, Jazakallah khair.
Another round of applause to our panelists. Thank you, Dr. Omar Tayari, for being a moderator on this very extensive topic. Now, we've come to the most important part of this conference, and that's the AGM, which is next on our program. So we will break for swalahs and tea break. We are all, please underline, bold, italic, expected to be back for the AGM at 5:20. Okay? We are all, please, everyone who is in this room, we are all members of Kammp, and to support Kammp, you have to be in the AGM so that you can see what Kammp has done and we can actually interact with our colleagues who are leading the Kammp management. The bus will be leaving for Mombasa town after Maghrib prayers. So the bus will leave at around 6:20, okay, to Mombasa. And tomorrow the bus will be leaving from Coast General at 6:45 a.m. For those who are boarding the bus, please be at Coast General Hospital by 6:45. Those who want to be picked from Sheikh Khalifa should be at Sheikh Khalifa by 6:50. So we break now for prayers and a little bit of some tea break. We should be back by 5:20. We are all expected to be in this room for the AGM. Shukran wa jazakumullahu khair.